Okay, we are on time. So, good night, everyone.
And this is my Laboratory, our own dental educational academy platform, our own dental software, which is called DenSoft. So we can control all the clinics with this software, which have CRM and ERP features. 5 software developers is working now in-house, like Pedro Costa, like Javier Lorenzo, Susana Palma, Vada Sabuni, Matias Pepper, and many, many more. So if you are really interested, you can just click this website, tas2022.com, and we can meet in Istanbul in 2022. So this is my clinic. As you see, we love to work with young dentists. I may be getting older, and I think they will fire me in a couple of years. And our clinic is a multidisciplinary clinic. We have 14 chairs. I just work on Friday and Saturdays, and I just do Invisalign therapies. But we work with 3 orthodontists, and I'm doing Invisalign treatment since 2011. And so far, we treat 75% of our ortho patients with aligners. Of aligners, do we really know the limits of when to use auxiliaries? And actually, what is advanced cases in Invisalign or aligner therapies? And can I really design a user-friendly treatment plan to my patients? And tonight, I just want to try to give you a slightly different perspective about aligner therapies. So what is advanced cases for aligners? Severe crowding or spacing are advanced cases. Class 2s, if more than half cusp relationship is present, it's advanced cases. It's the same for class 3s. And open bite, if we solve with posterior intrusion and anterior extrusion combined together. Deep bites solved with posterior extrusion and anterior intrusion, and of course, extraction cases except lower incisors. So before advanced cases, what is best for us to be experienced before starting the advanced cases are, of course, class 1 with minor or moderate crowding or spaces, distalization between 1 or 2 millimeters, deep bite solving with relative intrusion, and open bite solving with relative extrusion, and lower incisors extraction. It's much better when we go before the advanced cases. So today, this is Mr. X. We will talk a lot about him tonight. This case was the 3rd runner-up in Invisalign European Scientific Symposium Awards in 2020. Unfortunately, there was a pandemic where it wasn't a live event, so it was a webinar. And so let's talk about Mr. X. I treated him in 2017. He was 29 years at that time, and the total aligners was 56 plus 13 additional aligner, and the second additional aligner was 10 aligners with a total of approximately 80 aligners. So the treatment time was 30 months. It's a little bit long, I know. But at that time, I was changing my aligners every 2 weeks, we can say 15 days. And I change it at the additional period, like 10 days. So what we have in Mr. X is we have class 2, division 1, narrow upper jaw. You can see from the smile, we have black buccal corridors. And excessive overjet, we will look to the intraoral photos, and we will just look at the clean check too. The supernumerary lateral, midline discrepancies, and edge-to-edge bite. So this is the profile. You can see how the smile and the canine position and the incisors position is. And yes, this is the intraoral photos. So what we have here is we have a class 2 relationship on the molar, and and the canine at the right side. And the canine is a little bit infrapositioned. We have proplined incisors, as you see, on the lower and upper. And there is midline discrepancies. We have axial angle problem on the incisors, as you can see. And you can see the superlateral and the class 2 relationship of canine and molar on the left side again. So we have a narrow upper jaw and a slightly narrow on the lower jaw. Thanks God, we don't have too much work on the lower jaw. So let's go to the clean check. So when you look at the clean check, we can see everything much more clearer, because if you take the photos, you have some angle problem. You cannot see the 7 correctly, but you can see much more better how the overjet is so excessive, and the inclination, the proclination of the upper incisors and the lower one, you can see everything much more clearer, and everything, the narrow upper jaw. And here, for the treatment plan, the superneural lateral was extracted, and you can see the lower jaw. So what was my treatment plan in Mr. X was, on the left side, I did distalization, and we did expansion on upper and lower jaw. We will talk about expansion. And extraction. So I extracted 1.4 teeth and the superneural lateral. So today we will talk a lot about of Mr. X and the cases. So the first one, we will just distalize the lower. So our chapter 1 will be the distalization. And the second one, we will talk about the expansion of upper jaw and of course the lower jaw, how we do the expansion. And chapter 2 will be the expansion. And finally, we will extract the 1.4, and we will talk about extraction cases. So let's start with chapter 1, distalization, the sagittal anomalies. So when do we do distalization? We mainly do distalization in class 2 cases. We do distalization in class 3 cases. We can use distalization if we have to gain space, and we can perfectly treat midline discrepancies with distalization movement. And if you look at standardized, this is a chart from standardized book, which is an excellent book. And when we look at the dental anterior posterior correction, if we have less than 2 millimeter anterior discrepancy, we can treat it with posterior IPR, and we can use class 2, class 3 elastics, and we call this as a simple case. But if you want to be more conservative, if you don't want to do any posterior IPR, you can do sequential distalization in these cases too. So if we look at the moderate one, if it's 2 to 4 millimeter anterior posterior discrepancy, we can use class 2, class 3 elastics combined with maybe posterior IPR, and we can do, of course, sequential distalization. And if we have more than 4 millimeter anterior posterior discrepancy, that means we have full cusp relationship, class 2 relationship, for example, then we may exist the buccal occlusion, and then we can consider the extraction. So if extraction is, when we do extraction, then it's automatically an advanced cases for aligner therapies. So we can do in this part the distalization, and if we have more than 4 millimeters, we can think about extraction, or we have to use stats. But there is a question mark here. The moderate stage says 4 millimeter, which is 4 millimeter distalization. It's not actually so easy. 4 millimeter, you may use maybe some mini screws again. Okay. So which case are the best for distalization. So today I want to talk about a little bit about the user-friendly treatment plan. So all cases, what you will see tonight is just treated with aligners, attachments, and maybe class 2 elastics. That's all. No TATs, no power arms, no other auxiliaries. So that's why I want to talk about a little bit about the limits. So let's look at the studies. There is a nice study from Serena and her friends, and the conclusion was the aligner therapy in combined with composite attachments using the composite attachments and class 2 elastics can distalize maxillary first molars by 2.25 millimeters without significant tipping. And the other study is that from Gabriel Rossini and his friends. They concluded as mesiodistal tooth movement revealed the highest predictable with a molar distalization up to 2.5 millimeters. So actually these studies are made in 2016 and 2017. And as you know, Invisalign is introducing us new attachments and new features every year, as you know. So if there will be more studies, probably at the recent years, like 2021 or 2022, these numbers will be increased for sure. So distalization case, this is Miss J. She was a French, she was an expat living in Turkey. I treated her in 2016 in the age of 26. The total aligners was 37 aligners, and I just asked for additional aligners just for the lower and 10 aligners. And the total treatment time was 18 months. And the aligner change at that time in 2016, I was changing every 2 weeks. It was 15 days. So what we have here, the case is class 2, division 1. We have a narrow upper and lower jaw. And we have midline discrepancies and of course crowding. You can see how the crowding and the narrow upper jaw from the so this is the intraoral photos. You can see the class 2 relationship on the canine, and you can see the excessive overjets on the upper and the angulation of the incisors. You can see the narrow jaw on the upper, and there is a classic V shape on the maxilla and rotational problems on the premolars and retracted lower incisors. And we have a baby tooth on the lower left side. So we won't give any force on this. It's very an advantage for digital treatment, for Invisalign treatment. You can arrange and you don't give any force on that baby tooth if you want, okay? So we have class 2 division 1 case on Miss J. So this is the OPG. Of course, we extracted the upper eights for distalization. And let's look at the clean check for the treatment plan. We have 37 aligners for upper, and we have 27 aligners for the lower. And if we look at the numbers, we can see on the 17, we have 1.8 millimeters distalization. On 6, we have 1.8 millimeters distalization again. And if you look for the 2.7, we see we have 1.7 distalization. And again, 2.6, we have 1.7 millimeter distalization. So if we look at the studies, that's a really easy case for distalization. It's not the advanced cases. We can easily distalize these upper molars. So let's look at how the clean check is. I used precision cuts because it's not a class 2 division 2 cases. As you all know, in class 2 division 2 cases, it's better to use button cutout because there is it nurtures the intrusion effect of the aligners. And you can see the interesting thing, I didn't use any attachments on 7 and 6 on the right side. I always use button cutout on the lower. And on the left side, I didn't use any attachments on 7, 6, and 5s. So in the last year, as I told you, in 2011, at that time, Invisalign didn't put too much attachments on the posterior. But at late, of course, there's G8 technology, the G8 system, and it's a really nice system. But if you started earlier, you will notice that nowadays they are putting every teeth and attachment. So this case is interesting. I will show you the upper again. So here, I didn't put any attachments. And as you all know, if we have a more distance, more distalization movement, some doctors and speakers do the distal out rotation on the 6 to gain a little bit space and to minimize the distalization distance and minimize the aligners, total number of aligners. So if we look at the 6, what we did with the rotation, it's just 6.3 degrees. And the other one, if you look, it's just 1 degrees. So in this little rotation movement, I don't need actually any attachments. And the other hand, if we look at the expansion on that time, the buccal is just 0.1, 0.5, and the other side, if you look, is 0.1 and 0.3. And it's actually moving lingual. So the expansion side is more on the anterior. So I don't do any expansion, too much expansion on the posterior, and I don't rotate. I just do directly distalization movement on the molars. So that means that I don't need any attachment on the molars. The aligners can just easily move the molars to the posterior. So let's continue. Sorry. Let's go back. Yes. So on the lower, I did a little bit IPR because I want to control the propionation of the lower incisors. And we have rotations. We will put the attachments and we just procline and expand the lower one. And as you see, we didn't give any force to 3.5, as you see, no movement. So this is after the situation of 13 months, which means that we finished our lower aligners. So you can see we are still continuing with the upper, and you can see the distalization gap. We are just going through the treatment. We didn't stop. And if you see, it's almost the midline is almost finished. And on the right side, everything is going to the class 1 relationship. And it's the same for the lower one of the left one. And you can compare, it's matching with the virtual and the real. So you can see from the occlusal, the virtual and the real one. So you can see we have still gaps between the canine and premolars. So we are continuing our treatment with the upper aligners, but I didn't like the finishing of the lower. You can see the rotations on the premolars, on the canines, and on the 45. And a little bit on the 43. So I just asked for more aligners for lower. It's just 10 aligners, and you can see we just giving just minor movements, mainly rotational movements on the premolars and on the canines. So we wanted to finish in a better position, of course, and just 10 aligners. So it was a luck to finish. The upper were 37 aligners and the lower 27 plus 10. We finished both arches in the same time. That I didn't arrange it. It just came like with 10 aligners. So this is after 18 months, the final photos. You can see we have perfectly matched the class 1 relationship on the molars and on the canines on the right side. And you can see on the left side, everything is settled with the class 1 relationship. The occlusal relationship of the baby tooth is very good. There's no problem. You can see the midline. It's very good match at the end of the treatment. And you can see how we expanded the upper and lower perfectly. So you can see the baby tooth. It's a little bit lingual positioned because we expanded the lower jaw and we didn't give any tooth movement on the baby tooth. Yes, so we compare at the beginning and the final one. You can see everything, the tooth, the proclination, and the overjet is everything is fine seated. So what we can do is we ask for Ms. G to do bleaching and a little bit laser gingirectomy because the gingiva isn't at the same level, but she didn't want it, or we didn't insist, but that will be much better finishing, I think. You can see from the occlusal, the upper and the lower. And the face, the final, a very good smile line. It's, as I said, a little bit bleaching, and the gingival contour with laser will be much more better smile, but it's okay, she was happy. And the beginning and the final one. From the profile, and she's a happy patient. So if we compare the digitalization with the conventional orthodontics, there are many studies like Herb's fixed appliance. The total amount was 33 months. Force's fixed appliance was approximately 30 months, and pendulum fixed appliance are all 30 months. These are really long treatments. With Invisalign or aligner therapy, we can reduce the time. In Miss Julie, Miss G, the total treatment was 18 months, but I told you that I just changing every 2 weeks, and now I'm changing every 10 days my aligners. So if Miss G was now my patient, probably the treatment plan total time will be 15 months, something like that. And it means that it's almost the half of the conventional orthodontics. So let's go back to Mr. X. We finished our distalization movement. Now we know how to do the distalization. And chapter 2 was the expansion. And now let's talk about how we do expansion. So chapter 2 is transversal problems, the expansion. So this is Mr. F. I treated him in 2019. He was 36 years old. And at the beginning, we just get 22 aligners and with 21 additional aligners. And the total number was 43 aligners. And the whole treatment time was 14 months. And in 2019, I changed my aligners to every 10 days. So it's a quite good time for a transversal treatment plan. And as you see, we have on the smile, we have black buccal corridor on the smile. We have anterior and posterior crossbars, as you can see the laterals. Class 3 tendency, we have open bite tendency, edge-to-edge bite. We have narrow maxilla, crowding, and rotations. And we have everything in his mouth, actually. So this is his OPG, everything is fine. We didn't extract any eights. And this is the intraoral of Mr. F. So what we have here is the crossbite starts from the 6, goes to 5, and it's almost edge to edge with the 4 and with the 3. And you can see the angle of the lower canines. We have a mesially tipped lower 6 on the left side and with the right side. And the crossbite is almost the same as the left side. We can see the 6, 5, and 4. We cannot clearly see the 7. We will check from the clean check how the 7 is. And from the frontal, you can see the midline discrepancy. You can see how the poor bite we have, and the narrow upper jaw, you can see how it is. So from the occlusal, you can see the 7s. The narrow side is almost the middle. The premolar region is much more narrow if you compare with the whole maxilla. The sevens are much more better positioned. And if you look at the lower, there is an interesting situation. You can see the narrow on the upper, the edge-to-edge bite. And there is an interesting situation that we have buccally moved lower six on the left and the right side. This is buccally moved too. If you compare it with the 7 and the 5, it's the same position on the left side. The 5s and 7s are more lingually tipped, and the 6 are more buccally tipped. So we can use this as an advantage. I will show it from the treatment plan. So let's look at the numbers again. We have with Invisalign, we have a very good tool. We can look at the Bolton, we can look at arch distances. We have all the calculation now, and it's a really big advantage to do strategic treatment plans to our patients. Okay, so if you look on the upper, you can see how the narrow is. Let's look at the numbers. If you look at the canines, it's 32.8 millimeters. And on the lower, it's 27.8 millimeters. It's something like okay. But if you go to the premolar, we can see it's 32.5. And in the lower 32, it's getting narrow on the upper. And at the 5, it's 33.3 millimeters. And if you go to the 4, it's 36.4. It's the narrow. Here is the biggest problem. And here, if you look at the 6, it's 41 millimeters. And on the lower is 46.3 millimeters. So what is advanced cases for Invisalign, the prescription form? If you look, if we have less than 2 millimeter per quadrant expansion, it's an easy case. And if we have between 2 to 3 millimeters expansion per quadrant, it's moderate. And if we have more than 3 millimeters, then it's called an advanced cases for Invisalign treatments. If we do expansion, the most important thing is we have to consider the periodontal health, because we cannot see from the clean check any bones or any gingiva conditions. So we have to really very careful. We have to look from the 3D tomo or others from the intraoral examination. And it's really very important to consider the periodontal health before the expansion. So there is a really nice study from Jean-Philippe Holl in 2017. They looked at 64 patients studied and 20 crossbite cases, at least one tooth must be in crossbite. And they change every 2 weeks the aligners, and the average time was 56 weeks, which is not so important for us now. And what they look is they compare the real one and with the clean check one, with the virtual one and with the clean check one, how the percentage of match had done after the treatment. So they look in 2 movements, the bodily and the tipping one. They calculated from the gingival of canines between the 2 canines. And the tipping movement was calculated from cusp to cusp. So if we look here, the numbers is the bodily movement was the approximately 63% matched with the real one and with the virtual one. So what we can say in this study that in aligner therapy, we do mainly tipping when we do expansion. So we don't talk about bodily movement mainly in aligner therapies. And the other interesting thing in the study is, if you look at the both study, at the bodily and the tipping one, the match is the predictability of the movement is decreasing. So here is not so clear, but I think it's 89% on the canine. It's matching with the virtual and the real one. And if you go to the posterior, it's 84, it's decreasing. And between the 5, it's 81. and on the 6 it's 76.6. And they didn't study the 7, but if they would, I probably say that it will be 72 or 70%. So what does it mean? The predictability of tooth movement of expansion is decreasing if we go to the posterior. So we can do overcorrection on posteriors. That means that. And the other hand, we can probably use cross elastics to be more predictable expansion moment in our treatments. So I don't know if you just take the aligners and if you squeeze the aligners between the 3 and the 4s, you will see that it's much more stiffer. And when you squeeze from the 7s or 6, you can easily feel that it's much more flexible. And this study shows this exactly the same situation when we're squeezing it. And by the way, we have the G8 protocol. It's a very good protocol. I like it, but it's actually very new. They started to we are doing from 2021 this year. And there is an optimized expansion support attachment when we are doing the expansion, and it's minimized the tipping moment. And with this expansion support attachment, it's a support, and we can rotate the tooth in the same time. So let's go back, Mr. F. So if we look at the clean check, so we can see the 7s in a better position. You can see the narrow upper jaw. And when we do expansion, when we do conventional orthodontics with braces, as everybody knows, there is a vertical control. When we using the cross elastics, there is an extrusion force on the molars, and probably we are opening the bite at the anterior at the side effect. So in aligner therapy, because the aligners are covering all the surfaces of the molars, so we have a better vertical control, and we don't have many side effects about like anterior open bites. So in Mr. F, there isn't, as you see, we don't have any cross bites on the 7s, as you see. That's a good thing for us. So for auxiliaries, we can use the cross elastics. As you see in the third picture, I had treated many crossbite cases, scissor bites, non-buccal occlusal. I never used 3 elastics for my patients because actually it's really hard to wear them. And 3 elastics is really a big movement, a big force for them. So this is logically, you can put on the upper 2 and 1, but mainly I always give 1 cross elastics, and mainly I give it to on the 6. The 7s is much more hard to handle for the patients. So this is the treatment plan. So there is a lot of crowding. We do IPR on the upper to solve the crowding. And as you can see, we are expanding the upper. In this time, there were no G8 attachments. So we use other optimized and standard attachments. And in this treatment, I didn't use any cross elastics for Mr. F because the 7s are not on cross bites. So as you see on the occlusal, I will use the 7 as anchorage. And by the way, if you have more crowding on the anterior side, so there will be a bubble effect on the aligners. So it's a good effect for the aligners. So you can easily expand the middle of the premolars, okay? So you remember the lower 6 were a little bit tipped from the buccal. So I won't do too much expansion on the 6. I will give a little bit lingual movement to this lower six, as you can see, to compare and reduce the expansion, the distance of expansion for the upper, using it like an advantage. So we have 22 aligners for upper and 11 aligners for lower. I didn't give any axial angle for the lower six. As you remember, there was a mesial tipping on the left and right lower six. So let's see how we go through after 7.5 months later, when our initial aligners is finished. You can see we have almost done our midline. Everything is okay. But as you can see, we need a little bit more torque on the tools on the both sides. We had expanded. We may expand a little bit more over here. As I said, I didn't treat it here, but I will. So we have almost class 1 relationship on the lower. And you can see easily we have to move these two a little bit more buccally. Okay, so we can expand a little bit more. You can see how the 6 are moved lingually. So again, let's look at the numbers. So we just scan at the pre-treatment, and as you know, when we ask for additional aligners, we have to scan the patient again. So when the second clean check comes, then we can compare how much expansion actually we did, what we achieved. So let's look at the canines. It was 32.8 at the beginning. And at the first, the initial aligners is finished, it was 35.5, we expanded, nice. And look at the premolar, it's 32.5 to 37.7. And the narrow part, the most narrow part was on the 5s, it was 33.3 and 41. And that makes almost 8 millimeters. And remember, more than 3 millimeter was advanced cases for Invisalign charts. So on the 6, it was 41, and we did it 44.5. But if you look at the lower, between the 6 at the beginning of the treatment, it was 46.3. And at the end, we can see we contracted, we move a little bit lingually, the 6, and it's reduced to 44.4. So it's really a good tool. If you look at the numbers, you can see what you've done, and you can do many strategies when you want to design a treatment plan for your patients. So this is the second additional aligners. And the first additional aligners, sorry, we have just 12 aligners for uppers. We will give a little bit torque to the tools. You can see we have 5.7, 5.9 degrees, and we will expand a little bit. You can see we are correcting the 6, as you can see. And I just do a little bit IPR on the lower because I want to correct the bite on the anterior and give a torque and a better bite on the anterior for them. I used to doing here more 0.3 IPR, not too much. It's just okay. And this is the final. So you can see at the right side, everything is settled. We have a really good class 1 relationship. You can see how the laterals are good torqued, and the midline is perfectly matched at the end of the treatment. Here you can see on the left side. Here we just had a little problem. You can see I could do it a little bit better, but he had to go to London. He told me that I will go to London. I will move there. I asked him to get more additional aligners, but he didn't care about the posterior. He just said it's okay. I'm really happy with the treatment. So look at the upper, how beautiful it expanded. You can see the laterals, it's leveled perfectly. And you can see the lower 6 are lingually tipped, and the all anterior leveled perfectly. So you can see pre-treatment and post-treatment, and everything is fine settled. So look at the smile. You can see the buccal corridor, the laterals, and you can see the end. We did bleaching, of course, and you can compare the final and the beginning of the treatment. So he's very gone happily to London, to England. From profile, and yes, for transversal anomalies, you can do overcorrection on postures during expansion. If the expansion is between 4, 4, 5, 5, you do not need any cross elastics. You can use intraoral elastics when treating molar crossbites if 7s and 6 are both in crossbites. If you have 8s, you can use them, don't extract them. Use 8s for anchorage, and if you have 7s on the normal position, it is much more better. It's double anchorage. But if the 7s are on crossbite and the 6 are on the crossbite, you have to use cross elastics for sure. So let's go back to Mr. X. We finished the distalization. We talked about the expansion. And now we will talk about the extraction. So as you all know, I told you that I extracted these 1.4 and these superior lateral. Why this? Because this one position was in a better one. And if you compare which is symmetric with them, this one is much more symmetric. So that's, I decided to extract this one. So the other thing is I extracted the 4.4, but we talk about distalization. I do on the left side distalization. Why I can't do distalization on the right side? That's a question mark for me. So let's look from the clean check. You can see we have 51 aligners for upper and 21 aligners, I think, from the lower. And I did it in this same patient, the distalization movement. And as you see, everything is perfectly matched with the distalization. Everything is fine, no problem with that. And look up from occlusal, you can see with 51 aligners, we can treat the case with both distalization movement. But if you look at the numbers, you can see that we have 5.3 millimeter distalization on 17 and 4.7 for 16. So that's a huge number for distalization. So it's not predictable. So I changed my treatment plan to extraction. So this is the extraction plan. So you can see what is the interesting thing is now we have 56 aligners. We have 5 aligners more if we do extraction. But if you look at the numbers, you can see we have on the left side, we have just 2.5 millimeter distalization, 2.4, 2.4. And as you remember the studies, we can do easily 2.5 millimeter distalization. And mesialization is 2.1, which is acceptable. 2.9 is something like okay, but not 5 millimeter distalization if you compare, which is much more predictable. Means 2.9 millimeter mesialization movement will be much more predictable. So if you look at this treatment plan, we will have a little bit longer treatment, but we will have much more predictable treatment plan. So I decided to extract the 1.4 teeth tooth. So chapter 3 is extraction cases. The main problem of extraction cases is the same as aligner therapies and is the same for the conventional braces. So there's two main problem. The first is molar anchorage control, and the second is incisor torque control. So which cases are perfect for extraction or which aren't? If we have deep bite or retroclined incisors, for example, if we have class 2, division 2, these cases are not good for extraction. If more than 5 to 6 millimeter root movement is needed, it's not predictable. If we have 3 millimeter root movement, or 3.5 movement, it's getting harder to. And root inclinations that diverge away from the extraction size are hard cases. And interestingly, if we have minor crowding, it's not predictable for the extraction cases. We will talk about it. So which one is ideal for premolar extraction cases for clear aligners? If we have class 1 or mild class 2 maxillomandibular protrusion, these are good cases. And proclined maxillary and mandibular incisors, where some loss of torque will be acceptable, will be good cases for extraction. Mesially tipped canines with favorable root inclinations adjacent to the extraction sites are good cases for extraction. And crowding. Crowding are our friends for extraction cases. So for Invisalign, what is the prescription form? If we look the predictability, if you don't have any extraction, it's an easy case. If we have incisor extraction, it tells us it's a moderate case. If we have premolar extraction, it's an advanced case. So just talk about incisor extraction. Incisor extraction actually are easy cases. You can just go through with the incisor extraction. What you have to do is just put a vertical rectangular attachment to the neighboring tooth of the extraction site. And you don't need any staging. You can just simultaneously move the teeth and you can just easily correct the extraction side with the incisor extraction. So when we look at this study from Van Dai, I don't know he or she is, but I think probably he. They studied for 30 patients and they extracted maxilliferous premolar. And what they compared they compared the G6 optimized attachment versus 3 millimeter vertical, 3 millimeter horizontal, and 5 millimeter horizontal attachments. And this study was done in 2019. And the conclusion was, in extraction cases, initial crowding had an inverse correlation with the differences between predicted and achieved tooth movement in the angulation and mesodistal translation of the first molars. What does it mean is, if we have more crowding on the anterior side, the first movement will be the relief of the crowding movement. So if we have more crowding, the relief movement of the anterior will be much more. That means the posterior molars will move mesially less. With that, the mesial tipping will be automatically less in this case. So that's why crowding is our friends when we have extraction cases. And the second is, even if the first molar was set stable, it will actually move mesially 2.8 millimeter. We will have 2.8 millimeter loss of anchorage in this study, if they say so. So on the other hand, there's an interesting, which I mainly use, and probably you use this vertical rectangular attachment too. 3 millimeter vertical rectangular attachment showed the least anchorage control and had greater predicted and achieved tooth movement differences in first molar mesial translation. I will show it on the clean check. It's really interesting, but there is a discussion about it. I will talk about it later. So what auxiliaries we have for extraction? Of course, we have buttons and elastics. We have power arms. We mainly use power arms, and we use tats if we need it. So yes, we use power arms, we use tats, but if we need it, I didn't use any tats, I didn't use any power arm in Mr. X case. I just use button and cluster elastics. So let's go again to Mr. X. So the treatment plan was, we will distalize the left segment, we will extract the 14 and the supranumeral lateral, and we expand the lower and upper. So this is our real treatment plan. We have 56 aligners on the upper and 21 on the lower. And as you can see, we will mesialize 2.9 millimeter on the most, and we have 2.5 millimeter distalization. When we look at the Bolton, we have Bolton on the mandibular, and you can see the overjet is 6.6. It's really an excessive overjet. And you can see the bite, it's almost 0, it's 0.3. So what I did plan is, I know that I'm doing an asymmetrical extraction for this case. So as you can see, I'm using here the precision cuts. I didn't use any button cutouts because it's not class 2 division 2 cases. And here you can see the distalization movement of the canine. Here, what we talk about the vertical rectangular attachments. So the main thing is, the discussion thing is, if you need at least 2 millimeters plastic between the gingival margin and the attachments. If you have less than 2 millimeters, you don't get a better aligner engagement on the tooth. Okay, so that's really important. If you are using vertical attachments, you must be very careful. You have at least 2 millimeter distance, 2 millimeter plastic covering on the tooth. That's the main thing for a good control. And the other hand, if you do distalization, if there is no aesthetic concern of your patient, please ask him to not want the pontics. If you don't use any pontic, you have better control, you have better plastic coverage on the distal side of the distal surface of the canine and the mesial side of the premolar. So it prevents the mesial tipping and the distal tipping of these teeth. Okay, so let's continue. Sorry. Yes, we go to the other side now. So on the left side, we are doing the distalization. 2.5 is a good distalization. And as you can see, I didn't use any attachment on the left side. Okay. So here, the rotation is not too much. It's just 4 degrees. It's okay. We doing directly distalization movement. But the thing is, I'm doing distalization on the left side. There was a space because of we extracted the supranumeral lateral, and you will see from the occlusal better, we have a huge distalization of the these lateral tooths. Look at the number. We have 9.3 millimeter distalization. So I just put here the biggest attachment as I can horizontally on the lateral to control the tipping moment of the lateral. So yes, and I have give him 6.5 O's class 2 elastics just for nights, not every day, whole day, just he will use the elastic at night. So you can see the movement from the occlusal in a better position. You can see the distance here. I didn't do any IPR on the lower. I have on the mandibular a little bit. And actually, when I started with this case, I know that I will do additional aligners. So that's why I wanted to see at the end. And in the second and the first additional aligners, I will use the IPR option for myself. So what we do on the lower, we just do a little bit expansion, that's all. So there's not too much work. So this is the pre-treatment on the upper. You can see at the 35 aligner, the situation, and look at the clean check and the real one. You can see that we have a really overjet problem here. We had closed the extraction side on the left side and the right side. We are close the distalization movement. We have just using the lateral, but here you can see it's not matching the origin. Why? Because Mr. X, he was an engineer, and I think you all know that engineers think a little bit differently. He wear his class 2 elastics not just only at night, he just wear it 24 hours because he thought that if I wear them 24 hours, my treatment will be much more quick and we will finish earlier. And because of these heavy class 2 elastic, we had a jump effect over here. So I just said that stop using class 2 elastics for a while. We will pause it, just use your aligners. And please listen to my direction. I told him, and he said, okay, I will. And when we look at when we finish our first initial aligners with the 56, you can see the situation. We have actually edge bite. We have closed the extraction site. We have here the full class 2 relationship. We have class 1 relationship. We have the midline problem. We have the class 2 problem, but we have perfectly closed the extraction sites. You can see the proclination because we didn't do any IPR on the lower. So if this case comes like a new case for you, a new patient like you, this is an easy case now for me. So what I planned is, on the other clean check, is we just using the IPR option for me. It will be on the right side more because I will correct the midline. And I will use class 3 elastics on the right side and class 2 elastics on the left side, okay? So if you using class 2 on the other side and class 3 on the other side, that's a really not dangerous, but you have to be very careful. If you give all the aligners to the patients, all 20 aligners, you will probably get a problem. Why? Because it's not the same as conventional orthodontics, because the aligners is covering all the surface, occlusal surface of the teeth. So the friction is less. So the jump effect or the transverse effect is much more easily. So in my opinion, you have to give the appointment maybe every 1 month or 1.5 months will be the best appointment schedule for these patients when you use here the class 3 and the class 2 for the correction of the midline. Okay, so you will see how it's going. We are doing the IPR on lower for a better bite and to correct the midline. And you can see there is really less attachments. We are just extruding them, and we are using the class 3 over here and the class 2 over here. And you can see the optimized extrusion attachments on the left side. So let's look at the final. So we had 20 aligners in the clean check, and look at the 13th aligner, the situation. Everything is okay. We have class one on the left side, and the midline is okay in 13 aligners. So that was what I mentioned. But I told Mr. X that we can do it better. I didn't like the bite over the laterals. We can do a little bit more IPR on the lower, and we can extrude a little bit the upper anterior for a better bite. So I asked him, can we go another additional aligners? And he just said, okay, we can go with it. And I just scan him again, and you can see that we have these optimized extrusion attachments on the upper. We have just 10 aligners, and I do a little bit IPR. I'm just on the limit, not more than 0.5. I just do 0.2 millimeters to get a better bite. We will just do a pure extrusion movement. That's why we are using these optimized attachment, and they are working perfectly. You can see the movement on the right side and on the left side. And the final. So you can see we have class 2 relationship on the molar. We have class 1 relationship on the right canine, perfectly matched midline, and class 1 relationship on the left side canine and molar. You can see the upper, how perfectly it aligns, and the lower one. Now the proclination of the lower is much more in a better position. And you can see the pre-treatment and the final one, how we go through whole treatment. We have matched everything perfectly. The bite is really much more better positioned. If you look at the lateral, we have gained a little bit bite more at the end of the treatment. The upper and the lower occlusal photos. And you can see here the smile. I take every photos of him, so you can see how asymmetric smile we have. And when we go through the treatment, you can see when the treatment is going, you can see how the axial angle, the asymmetric smile is going to a symmetric one. In all the treatment time, you can see how perfectly his smile is getting much better and better. And this is the end of the treatment. Beginning at the final photos. Just aligners, attachments, and class 2 elastics. From the profile. So procline, maxillary, and mandibular incisors are our friends, and more crowding means more control over the angulation of the molars, of course. And for the final, what I want to say is we have to learn how to use the numbers. And Invisalign was invented for aesthetic treatments. I don't say we don't have to use power arms or tests. We must use them. We must use the power arms. We must use the attachments. We must use the other auxiliaries, of course. But we have to control the numbers and look at the numbers, and we have to design the best treatment options, the comfortable one, the aesthetic one, and always consider about the user-friendly treatment plans. So thank you very much for taking time for me. It was an honor to speak to you. So if you have any questions,
Let me
lovely
just go
answer.
through the questions. Well, maybe if you want to put your micro on, some of you can make directly the question. It will be easier. So, Statis, if you want to start, because you are the one with more questions.
As usual.
Do it, please.
Yeah. Let me also go a little bit back because the questions were in the beginning, so I have to remember what I've asked. Just a second.
While you are looking at it, let me just say that I totally agree with you that we should look at the numbers. And nowadays we see a lot of doctors using aligners, but at the same time they are just putting 8 TADs, power arms, and crazy things that sometimes we don't need. So I totally agree with your approach.
Okay, I have one question that I didn't realize why it was mentioned. Why do you think that you show a case that you compare the treatment time between the pendulum and the forceps and the aligners by the time you were still using the 15 days? And you said that if you were using the 10 or the 7 days, you would go half time. So what is the reason that we can go half time with aligners? The mechanics are changing?
No, the main reason why we can reduce the time is you can start at day 1 distalization. When you use the pendulum, you have 3 stages. There was another study I didn't show because I didn't have too much time, but you have to use the pendulum or Kelesh slider, whether else you just for the conventional orthodontics, you have to use them maybe approximately 8 months. And after that, you have to stabilize for NANS appliance, and then you go to the fixed orthodontic treatment. And in that study, it says that it's almost 30 months, the conventional one is. As you know, we have to do, in the other hand, of not just for distalization, if you compare with the conventional one with the Invisalign or aligner therapies, we can't go through to the SS wires, for example. We have to go for 0.12, 0.14, 90. We have to level it, right? But in Invisalign treatment, we don't have to level. We just can start. That's gaining time for us. That's a big advantage, I think. But when I changed 2 weeks, at that time, there was no too much education, especially in Turkey. It was just, you do it so you get it the final. And I was changing every 2 weeks. That's a long time. But even if it's a long time, if you compare with the conventional treatment, it's much more easier and much more faster.
But the fact that you used that case at the period that I didn't see any MA, probably the MA did not exist then.
No, I didn't do any MA. It's a dental, just dental.
Just dental. Okay, because I saw
Yes.
the forces, and I believe that there is some orthopedic effect with the forces. So, my questions are for one reason, because I see all of us, we try to give up. I hear lectures about people not using RP at all, people not using extractions with the aligners, that they're using less of this, less of that. And I don't know where we can stretch the limits of the aligners. And I'm trying to find the truth, because sometimes you're trying to do more and you fail in the end. That's why I'm asking all these questions about growth and all this stuff, and we replace things. That's the only reason. Okay.
You are absolutely right. It's confusing, but we need more studies. There are less studies about aligners, as you all know. And the other thing is, Invisalign or other aligner companies are technology companies. They are not like we get used the old-fashioned companies, right? They are technology companies, and they are developing. They have to develop every year. They have to get every year a new feature. So the studies are changing, right? So every year the university must have studies about all the attachments. For example, I don't know if there are any studies about the G8 protocol. Okay, so the university is coming behind, but the company is going much more faster. So we need more studies if we have control the numbers. That's another problem, I think. But you are absolutely right. It's a little bit confusing. I think the main thing is everyone will. I just shared my experience, what my limits are. That's all.
No, it was very well documented, and the reason is that I'm getting a lot of data from your lecture, and that's why I'm trying to absorb in 1.5 hours all this stuff. It's very, very difficult every time I'm trying to get the most. So another thing I got confused when you were showing that you said that there is more predictability at the expansion as you go to the posterior.
Yes.
But as we have known up to now, at least when we're using the RPE, we had more expansion in the front than in the back. This is the reason that you show us that the aligners are more elastic in the back, so they spring more and they expand easier in the back than in the front. I didn't get it. What is the reason that it's more predictable in the back?
I didn't understand the last one, sorry.
Because you said that there is more predictable about how much expansion. Of course, you are talking about tipping, of course. But
yes.
You said that in the back, it's more predictable, the percentage.
No, on the back, the posterior is less predictable because it's much more flexible. And because
it's not strong enough to expand.
Yes, you have to do overcorrection, or you have to give cross elastics to handle. Okay.
Okay.
Yeah. Thank you for your question.
Thank you very much for the answer. Thank you.
Pedro.
Yes, please.
I have a question about cross elastic. In the past, I used a lot crisscross elastics. Nowadays, I'm just thinking that sometimes we lost something. We lost some power of aligner to push the teeth. Look like that if we cut too much the aligners to put the button, we cut also the power of aligner to expand. So I want to ask him in which state of the expansion you use cross elastic, at the start or at the end of expansion?
At the beginning. But in one case, it was a really hard case. The lingual molars was really tipped lingually. Okay, so there was no space to put a button on the lingual side of the molars. So what I did is I couldn't do it. So I was changing the aligners every 10 days, and I told my patient that I can't put the button. So please change the aligners every 15 days. And when the molars has tipped a little bit buccally, and when I have a little bit space to put the button, then I started to put the button. That's the only case I do like that. But if I could place the button, I start at the beginning.
Okay.
I start at the beginning. I know that it's for the distalization too. Many doctors says that there is enough anchorage in the anterior when you distalize the molars. For example, when the sevens are distalizing, they don't use any class 2 elastics, but I just use at the beginning.
Okay, I was only asking because the aligner sometimes has the power to expand, and with the elastic, with the bottom cutout, we cut the power of aligner to expand to cover all teeth, you know. So okay, okay, thank you.
But no. But I said that I mainly use the button cutout on the 6th. I don't cut from the 7th.
Okay.
So I can use the 7th or 8. If there is an 8, then I can use it as an anchorage.
Thank you.
You're welcome.
I don't know if is there any other question. If not, thank you one more time, Dr. Sihan. It
You're
was
welcome.
a pleasure, and hope to see you soon.
Yes, you too. Take
Bye
care,
bye.
everybody. Thank you. Bye bye.
You.
Good night.
Bye bye. Goodbye,
Bye,
everyone.
bye. Thank you very much. Thank you.
Thank you.